Hi, my name is Brian Verla. This is my video presentation on gold standards for COPD exacerbation. This is video 1 of my video presentation series for this presentation. Thank you. So this will be our outline identifying COPD. We will be discussing what is COPD, what is known causes for COPD, how COPD is diagnosed, including its factors, testings, assessments, etc. We will also be noting key indicators for the diagnosis of COPD and the classification of airflow limitation severity in COPD scale and how that ties in together for the understanding of how severe a patient's COPD is currently and will be if they continue on the road that they are, that got them to that point. So what is COPD? COPD is a chronic obstructive pulmonary disease. It is an ongoing lung condition that's caused by damage to the lungs, and the damage could be somewhere in lines of swelling and irritation, also caused by blockages due to sputum production as well. It limits the airway for better aeration, which is also known as the obstruction. So what are some symptoms just off the bat? Well, your patients are going to show symptoms of dyspnea or trouble breathing, daily productive coughing, and sputum production. So they might even develop wheezing due to that chronic constriction of their lung vessels. Daily productive coughing is what you're going to be calling a chronic cough in patients. So these are patients that just constantly have a cough without intervention. That's usually what happens. They'll just have a continuous cough that's both detrimental to their health and also non-productive in the same boat. So what are some known causes towards COPD? There are often caused by long-term exposure to irritating smokes. So we're talking about like chefs or cooks that are constantly in front of a steam, they're cooking up whatever they're cooking. If it's creating any sorts of like heat dynamics such as steams or any other types of smoke that could be damaging towards your lungs. Fumes as well for any sort of chemicals. Dust, it's a big one as well. That could be a trigger to exacerbations as well. Most common are cigarette smokes, and that should be pretty straightforward. A lot of smokers develop COPD just because of how their lungs degress from a healthy state. So what are some diagnoses or disease processes that could entail COPD? Well, those are going to be emphysema and chronic bronchitis, which are the two most common ties to COPD, and usually they occur together. So they usually occur together and can vary in severity and among people with COPD. So what is chronic bronchitis? It is an inflammation of the lining of the bronchus or bronchi, preventing good airflow aeration and creating increased mucus production. So this is where you'll see a lot of narrowing of your lung vessels, a lot of inflammation. So an inflammation turns into sputum production. So you have all these sputum trying to get out, but then again, COPD have chronic coughs, so they're unable to develop a good cough for them to expectorate all those sputums and mucus plugging and other sorts of disease process that could be happening. Emphysema, so that's what's going to be causing your lungs to be, in a sense, over distended. They're basically just flabby. These are lungs that no longer hold their elastic properties, so they cannot open and close as functionally as a normal human being would be. This is the alveoli are damaged to the point that oxygen can't pass, which in turn causes a decrease in oxygen in the bloodstream. So now you have this person who is unable to ventilate, unable to oxygenate. In turn, they're turning hypercapnic and getting all sorts of pH levels that are all over the range. Of course, unless they are compensated. But even then, that would be a big if. So again, these are things that are usually seen together, and just take into account with that. So for diagnosing a COPD, what are some signs and symptoms? Again, like I mentioned before, dyspnea, chronic coughing, sputum production, but a big thing is that they do develop, respiratory tract infections. This could be history from before, present, or the possible future for that patient. Have these patients been exposed to certain viruses like a pneumococcus virus or a flu-like symptom virus, or even just as like simple as a cold, COVID-19? These are symptoms and signs that could be present. Recurrent wheezing. Are they constantly wheezing even though they have a treatment regimen? When are these triggers being activated? So that's something to keep in mind when assessing your patient. Key factors or testings that could be linked towards COPD and to helping a diagnosis that, and this is mandatory by the way, spirometry of a post bronchodilator FEV1 over FEV2 that's less than FEVC that's less than 0.7. So that is their mandatory. That is your gold standard there. Determine severity of airflow obstructions. So we need to see, like, are they getting enough volumes? How are their capacities? What is their raw? We want to know what their pressures are doing. We wanted to determine, like, how bad is this? What do we need to put this patient on? What can we do to make this patient better? Patient's health statuses, the risk of future events such as exacerbations, hospitalizations, and even death, because again, this is a serious issue. Pulmonary function testing, volumes and capacities. We want to see where those values are at too. Their DLCO, are they perfusion? Are they getting the right CO2 out? Pulmonary function, chest X-rays and CT scans can help with the diagnosis of other lung processes that could be either developing or have already been developed and is what caused the COPD to occur. We need to make sure that there's no consolidations and if there's any signs of pneumonia, in the lower lobes, just to make sure, because these are COPD patients, but then again, these are patients that have lives and they want to live a healthy lifestyle, they want to live long, but of course, that's going to hinder them. Continuing with diagnosing chronic cough, these are both an intrathoracic and extrathoracic signs for these disease processes. So a chronic cough could be indicative of asthma, lung cancer, TB, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, and idiopathic coughs. Again, it's a lot. For the other processes would be chronic allergic rhinitis, post-nasal drip syndrome, upper airway cough syndrome, gastroesophageal reflux, medications like ACE inhibitors. These are going to be present in these disease processes. That's why it's important to make sure you gather all the information that you might need to make a proper diagnosis for your patient and their longevity in the future. And lastly, the classification of airflow limitation severity. So think of this as a 1 through 4 process or step ladder. So our goal 1 is basically going to be your mild patients. These are patients that are not as healthy as they could be, but they do have signs to have improvement and have a very functional lifestyle past quitting smoking. So they might need a FEV1 of greater than 80% predicted. If they're goal 2, it's a moderate stage. That's going to be 50%, between 80% of their FEV1 predicted Gold 3 is severe 30 to 50. Now this is where you're starting pretty worse. That's an FEV1 between those two numbers. And then the last of all, the very severe FEV1 of less than 30%. This is gold 4. That's just not where you want to be. These are patients that no longer have the will to continue on, and it's a sad thing to see. So those are the classifications of airflow, limitation severity. They help in the diagnosis for the patient, and I just want to say thank you for sitting in with my first video presentation of this video presentation series, and I will see you on the next. Thank you.